How do you do? I'm Michael Link. I am a professor of pediatrics in the Division of Hematology Oncology at Stanford University School of Medicine. The title of my talk today is Progress Against Childhood Cancer, an update. The past few years have been some of the most exciting for oncologists as the investments in understanding the molecular underpinnings of cancer have translated into novel therapies in the clinic. In this hour, I hope to take you on a short tour of the progress that has been made in treating children with cancer and the exciting prospects for the future of oncology. It has been more than 40 years since the signing of the National Cancer Act, which inspired the so-called War on Cancer. We can rejoice at the impact of this legislation on the lives of patients with cancer over the past 4 decades since it was enacted. In the United States, 5-year survival has increased dramatically, with the rate of deaths from cancer dropping 18% since the early 1990s. 12 million cancer survivors are alive in the United States today, up from just 3 million in the 1970s. Patients are living longer with improved quality of life. Looked at another way, more than 1 million U.S. cancer deaths have been averted over the past 18 years. There is still work to be done, but the growing number of survivors is a testament to what can be accomplished. For children, the progress has been made in the understanding and treating pediatric cancers has been nothing short of spectacular. I hope to provide you with a taste of that progress and the lessons we have learned along the way. I hope to convince you that high-quality care of children with cancer requires multidisciplinary collaboration. Second, what we learn from tumor tissue is critical, including its impact on risk stratification and therapy selection. Third, we have learned that childhood cancers are heterogeneous collections of diseases within traditional tumor types. Further, we understand that we have a duty to the survivors to understand the consequences of our therapies and to deliver treatments with these consequences in mind. Finally, I hope to provide a taste of the very exciting prospects for the future of pediatric oncology. First, a bit of background. Cancer in children is not a trivial problem for pediatricians. Outside of the newborn period, it is the leading medical cause of U.S. deaths in young people, exceeded only by accidents, homicides, and suicides. Nor is childhood cancer particularly rare. 1 in 300 children is diagnosed with cancer before the age of 20. There are approximately 12,500 new cases of cancer in children and adolescents younger than 20 each year in the United States, and more than 2,000 U.S. children and adolescents died of cancer in 2004. Taken together, childhood cancers represent the 6th most common cancer overall, exceeded only by the major adult cancers. The distribution of cancers of childhood is markedly different from what is seen in adults. Leukemias account for almost 1/3 of the cases. Brain tumors in aggregate are the most common solid tumors of childhood. Lymphomas are next most common, accounting for a major portion of childhood cancers, especially among older children and adolescents. An array of solid tumors accounts for the remainder. So how have we done over the past 30 to 40 years? In 1973, when I was in medical school, this paper summarized the state of the art for children with non-Hodgkin lymphoma. Fewer than 1/3 of children survived, and virtually all of the survivors had early-stage localized disease. Today, the overwhelming majority of children with non-Hodgkin lymphoma can be cured. Almost 100% of those with early-stage disease, more than 90% of those with advanced-stage disease, and 80% of children with the highest-risk disease with extensive involvement of the bone marrow and/or the central nervous system. During my residency, almost all of the children who would have fit on the blue and red curves died. And non-Hodgkin lymphoma is just one example. Progress in the management of children with cancer is one of the great success stories of modern medicine. There has been a dramatic improvement in outcome for almost every category of childhood malignancy. For childhood acute lymphoblastic leukemia, or ALL, the most common childhood cancer, which accounts for almost 30% of the cases, the progress has been most gratifying. This was a disease that was virtually incurable in the 1960s. In the most recent trials, 5-year survivals among children with ALL approach 90%. Truly spectacular progress over 4 to 5 decades. Even more amazing is the fact that very little of the progress in ALL, and for that matter for any of the childhood cancers, emerged from the development of new agents. Virtually all of the drugs used today to cure childhood cancers were available when I started my residency many years ago. So how do we explain these results? Perhaps there was an element of luck. Most pediatric cancers proved to be remarkably responsive to radiation and to some of the earliest anti-cancer chemotherapeutic agents. Many patients with disseminated malignancies, including widely metastatic solid tumors, responded to single agents, and many achieved complete remission. Application of these agents in combination adjuvantly led to durable remissions and cures. And perhaps the cancers of childhood are not terribly smart. In a remarkable address at the meeting of the American Society of Clinical Oncology several years ago, George Sledge divided malignancies into stupid and smart cancers. The key distinguishing feature related to the number of mutational drivers and the number of total mutations in the tumor genome. As Dr. Sledge presented so eloquently, stupid cancers are responsive, while smart cancers evade therapy through presentation with or the development of resistance. The degree of stupidness can be quantitated by the number of detectable mutations across the tumor genome. A study by Gady Getz and colleagues at the Broad Institute showed that compared to stupid cancers with few mutations, smart, carcinogen-induced cancers such as melanoma and lung cancer have a more than 100-fold increase in the number of mutations. The majority of childhood malignancies would qualify as stupid cancers in Dr. Sledge's classification and are remarkably responsive to treatment. That has been our good fortune. Other factors worked in our favor as well. First, pediatric patients are capable of withstanding and recovering from the most intensive therapies. They are mostly young people in prime physical condition, free of comorbidities, a situation that is regrettably changing rapidly as more young people develop obesity. Pediatric oncologists willingly collaborated with one another to hasten progress, and we have benefited from remarkable translation of findings from the laboratory into the clinic, which have revolutionized risk stratification of patients and choice of treatment, and have led to exciting new therapies on the horizon. Pediatric oncology pioneered the multidisciplinary approach to patients, something that is second nature to us today. There was early recognition of the need to collaborate beyond the confines of individual institutions. The rarity of individual childhood cancer types made it unlikely that any single institution could accrue sufficient numbers of patients to conduct meaningful clinical investigations. In the interest of advancing clinical practice, pediatricians adopted a collaborative approach to clinical cancer research and were willing to participate in clinical protocols written by other investigators. Pediatric cooperative groups emerged as important engines for driving research. Clinical trials became the standard of care in pediatric oncology, with a majority of children with cancer in North America participating. Findings from clinical trials were rapidly incorporated into practice, largely because the best treatment emerging from one trial became the standard regimen of the successor trial. The rapid fall in cancer mortality among children in North America closely paralleled the establishment and success of the National Cancer Institute-sponsored clinical trials cooperative groups for children, a success that has continued with the merger of the 4 pediatric cooperative groups into the Children's Oncology Group in 2000. One of the keys to recent progress has been close collaboration between the clinic and the laboratory. Such partnerships began with investigations of acute leukemia, facilitated by the ease of obtaining tumor tissue on repeated occasions from bone marrow and peripheral blood, the ease of making near pure preparations of tumor tissue, and the relative ease of cryopreserving leukemias in tumor banks from which investigators could withdraw specimens of interest. Access to tumor tissue was critical to developing key insights into childhood cancers. Beginning in the 1970s, we began to understand the heterogeneity of ALL, both in terms of immunologic diversity and the division of ALL into T-cell, mature B-cell, and B-cell progenitor phenotypes with vastly different clinical presentation and responses to therapy. The first clues of the importance of molecular abnormalities in cancer came from cytogenetic studies. Let me take a moment to clarify this. Here we see the chromosome spread from tumor tissue from a case of Burkitt lymphoma. What can be seen is abnormalities in chromosomes 8 and 14, demonstrating a translocation where a piece of chromosome 8 is translocated to chromosome 14. This chromosome rearrangement is an acquired abnormality which occurs only in tumor tissue, not in normal, somatic, or germline tissue, and the rearrangement is not random. It, or analogous translocations, occur in all cases of Burkitt's lymphoma. Elucidation of the genes involved demonstrated that as a result of the translocation, the MYC oncogene, or at least the business portion of it, is moved into the immunoglobulin heavy chain locus, where it comes under the control of the immunoglobulin promoter. In a B cell, this results in constitutive transcription of MYC. As a result, cells are unable to exit the cell cycle and continue to divide unchecked. Analogous translocations occur in cases of acute lymphoblastic leukemia. The most common ones shown here: 119, 922, or the Philadelphia translocation, 411, and 1221, or TEL-AML. We know a lot about the genes involved in these translocations and their implications. Multiple rearrangements and other abnormalities have subsequently been identified, including extra copies of chromosomes, or hyperdiploidy, and missing chromosomes, or hypodiploidy. These abnormalities have been characterized on a molecular level, and thus the molecular heterogeneity of each immunologic type of leukemia was revealed, resulting in the division of the disease into multiple subsets with differing genetic mutations driving leukemia, each with a different outcome on regimens then in use. Patients with B progenitor leukemias that appeared identical under the microscope could be reclassified based on molecular subtype into subgroups with markedly different prognosis. With contemporary therapy, leukemia is characterized by specific trisomies, or TEL gene rearrangements, shown in white and yellow, clearly fall into favorable prognosis subsets of leukemia. By contrast, therapies in use until very recently were clearly inadequate for patients with leukemias with higher risk features, those with translocations 119, 411, and 922. Yet empirical intensification of certain phases of treatment was successful in improving outcome even for patients with high risk features. The result has been a steady incremental improvement in outcome for all patients with ALL, study by study and era by era. Our most recent studies project that almost 90% of children with ALL will be cured. Of course, with improved understanding of the molecular drivers of leukemia, the hope was for the development of therapies directed specifically against the identified targets. The success of this approach is exemplified by recent results for the management of children with Philadelphia chromosome-positive ALL, so-called Ph-positive ALL, the highest risk form of ALL driven by the BCR-ABL tyrosine kinase. This relatively rare subset of children with Ph-positive ALL had a dismal prognosis even with intensive therapies. Allogeneic stem cell transplantation appeared to be the only intervention that was curative. In this translocation, the ABL oncogene, which is a tyrosine kinase, is translocated to the region of the BCR gene, resulting in a fusion gene product comprised of the N-terminal end of BCR fused to the business end of ABL, so-called BCR-ABL. In some contexts, this results in Philadelphia chromosome-positive CML. In ALL, the result is a very aggressive and difficult-to-treat form of acute leukemia. In both situations, BCR-ABL is the mutation that drives the malignancy. The development of a specific inhibitor of the BCR-ABL tyrosine kinase was one of the first dramatic demonstrations of the power of personalized oncology, where a specific inhibitor of a driver mutation resulted in a highly specific targeted therapy for that cancer. In CML, or Ph-positive ALL, the BCR-ABL protein phosphorylates a substrate by transferring a phosphate moiety from ATP, allowing that substrate to bind to a downstream effector, resulting in activation of multiple other downstream genes and the development of leukemia, shown on the left. As shown on the right-hand side of the slide, Imatinib sits in the pocket designed for ATP and prevents this interaction, inhibiting the driver of the leukemia, and in CML, elimination of the leukemic clone. The drug is not effective by itself in Ph-positive ALL, but recent studies demonstrated the feasibility and efficacy of incorporating Imatinib and second-generation inhibitors of BCR-ABL into intensive leukemia chemotherapy regimens for this subset of patients. In light of these very promising results shown on this slide, marrow transplantation is no longer recommended as first-line therapy for children with Ph-positive ALL, and their prognosis has improved substantially. The landscape of ALL now looks something like this. No fewer than 17 different diseases defined by immunologic and molecular subtype, but all looking the same under the microscope. Each subtype has its own implications for clinical presentation and response to therapy, and thus for risk stratification and choice of treatment. Our understanding of the heterogeneity of cancers is relevant to virtually every tumor system. In neuroblastoma, the underlying biology is the major determinant of the behavior of the tumor and outcome, and thus a key component in planning therapy. The result shown on this slide is just one example to demonstrate the dramatic impact of N-MYC oncogene amplification on outcome among infants with advanced stage neuroblastoma. For pediatricians, tumor sampling and molecular analysis of the tumor are a critical part of diagnostic studies for every newly diagnosed patient for appropriate treatment assignment. For example, proper risk stratification and treatment selection for children with neuroblastoma requires detailed assessment of clinical data as well as molecular assessment of the tumor. Recent data in childhood ALL suggest that things may be more complicated than we had hoped. Analysis of childhood acute lymphoblastic leukemia at relapse indicates that a minority of relapses emerge from a genetically distinct clone representing a true unrelated leukemia, shown here at the top of the relapse column. 42% of the relapses emerge from the leukemic clone present at diagnosis, with or without the acquisition of additional genetic lesions. But approximately 1/2 of the relapses arise from clonal evolution of an ancestral clone that exists as a minor, unappreciated subclone at diagnosis. This subclone survived chemotherapy, and at relapse, some but not all of the molecular lesions that were found in the leukemic clone at diagnosis are retained. The implication should be no surprise. The tumor is much more complex than is appreciated with current molecular studies, which may fail to detect a small population of tumor cells that nevertheless will be responsible for treatment failure. A recent study suggests that the problem of tumor heterogeneity extends well beyond childhood leukemia and may significantly complicate the notion of developing a recipe that is personalized to an individual's tumor. Here, specimens from metastatic renal carcinoma from different sites in the primary tumor and from different metastatic sites prove to have heterogeneous somatic mutations, leading to diversity of tumor phenotype, including gene expression signatures of good and poor prognosis in different regions of the same tumor. Thus, molecular profiling from a single biopsy may severely underestimate the genetic alterations found in a single cancer and may be misleading when used to predict tumor behavior. How important this molecular heterogeneity will prove to be remains to be determined. Nevertheless, the message should be clear. It's complicated. Let me turn now to yet another theme from pediatric oncology, a focus on survivors. Here we see the average years of life lost to cancer among patients who are not cured. Interpreted another way, it represents the number of years of survival we can expect for patients who are cured. For children, this represents nearly 70 years on average, 70 years in which to develop and cope with the side effects of therapy. For elderly adults with cancer who are cured, late effects of treatment with a long latency may never be seen. No such reprieve pertains to children and adolescents who live long enough to develop all of the manifestations of those health effects. Such late effects are not a trivial concern. More than 1 in 700 individuals now between the ages of 20 and 50 is a survivor of childhood cancer. Nearly 2/3 of those long-term survivors have at least one chronic condition, and more than 1/4 of them have a severe or life-threatening condition. Early lessons emerged from children treated with irradiation for Wilms tumor and Hodgkin disease, where we learned the devastating effects of high-dose radiation on bone and soft tissue growth when administered to rapidly growing young children. Late organ toxicities and the development of therapy-related second cancers are among the most distressing late effects observed. 2 developments resulted from these experiences. First was the establishment of studies of the late effects of therapy and quality of life of survivors. Survivors of childhood cancer willingly returned to the clinics where they had been treated years earlier for investigations into their health status. The result was a cataloging of late effects, some predicted and some unexpected, that plague survivors, interfere with their quality of life, and reduce their longevity. More important was a renewed determination to strive not only for cure, but to maximize the quality of life for survivors as well, a sentiment best articulated by one of our heroes, Giulio D'Angio, a radiotherapist and pediatric oncology pioneer who believed cure is not enough. As a direct result of such studies, pediatric oncologists looked critically at their therapies to determine those components necessary for cure and work towards eliminating those components that contribute only to toxicity. This led to attempts to reduce the volume and dose of radiation and even to eliminate radiation entirely in the setting of effective chemotherapy, where the safety of this modification could be demonstrated. An example is in the management of early-stage non-Hodgkin lymphoma, where we demonstrated that irradiation of primary sites contributed only toxicity with no improvement in outcome. We no longer prescribe radiation for children with non-Hodgkin lymphoma, nor for most children with Wilms tumor. In the management of ALL, cranial irradiation, once a necessary component of therapy for all children, is now reserved for a small minority at particularly high risk of central nervous system relapse. Current studies are designed to prove that radiation can be eliminated from the therapy of children with Hodgkin lymphoma. Cumulative doses of alkylating agents have been reduced where possible in order to preserve fertility and reduce the risk of therapy-related leukemia. Cumulative doses of anthracyclines have been reduced and cardioprotective agents have been added to minimize the risk of cardiomyopathy, a complication to which children are particularly susceptible. So what lies ahead? Amidst all the good news about the progress in management of childhood cancers, there are some sobering reminders that we still have work to do. If we examine the mortality from childhood cancer as the rate plotted against year of diagnosis over time, the progress that has been made is clear. Also clear is that the curve has plateaued since 2000 and that further advances are more difficult to demonstrate. It is evident that we have squeezed what we can from traditional chemotherapeutic agents. We have come close to optimizing the gains, including intensification of therapy up to the limits of patient tolerance. We need new paradigms if we are to make further progress. Among the new developments are a number of advances that promise to change our approach to patients. We have new and improved diagnostic and imaging technologies and new and more sensitive techniques for assessing response that already figure in patient management. PET scanning, which takes advantage of the Warburg effect, whereby tumors preferentially use glycolysis for energy generation and thus have high utilization of glucose, has proven to be a great technology for tumor staging and for assessing response. Normal tissues that utilize glucose, such as brain and heart, light up, but so do lymph nodes and other regions involved by lymphoma, as shown on this PET scan. Combined with concurrent CT scanning and overlay of the CT and PET images, we get a stunning and sensitive demonstration of sites of tumor, providing for very sensitive and accurate staging. MIBG scanning provides similarly sensitive and specific information for children with neuroblastoma. A key advance in cancer management is the understanding that the rapidity and quality of response, depth of remission if you will, are critical determinants of outcome. Patients who appear to be in remission nevertheless harbor varying numbers of tumor cells that must be eradicated with further therapy if we are to cure them. Assessing response to the first courses of treatment turns out to be highly prognostic for outcome. For example, using PET scanning, patients with lymphoma whose PET scans become metabolically negative early on fare much better than those whose scans remain positive. In leukemia, we are able to use immunologic or genetic markers unique to the malignant cells to quantitate the number remaining in the bone marrow when remission is assessed. Here, in a patient with ALL, the tumor population is demonstrated in green and clearly is markedly reduced by day 29 when the marrow is morphologically normal. But there are obviously residual leukemia cells lurking in the marrow, as evidenced by the population of green cells remaining. The proportion of residual leukemia cells can be easily quantitated by flow cytometry. And the proportion of leukemic cells remaining at the end of remission induction after the first month of therapy, so-called minimal residual disease, or MRD, is highly predictive of outcome. Patients who are MRD negative have only a 10% risk of relapse, the bottom curve, compared to a 72% risk of relapse for those with more than 1% residual leukemia at this time point. Lesser amounts of MRD are associated with lower risks of relapse. Obviously, higher levels of MRD then translate into inferior outcomes. Results are remarkably reproducible between studies. Here we see the marked inferior outcome for patients with higher levels of MRD, the purple, green, and red curves, at the end of induction. A key finding that one can act on such data to alter the outcome. Intensification of therapy for those with high levels of MRD, slow responders as they are called, results in a marked improvement in outcome as compared to continuing with standard therapy. Thus, this rather simple test at the end of the first month of therapy can be used to individualize the therapy for each patient, continuing as planned for those responding adequately and intensifying therapy for those with unacceptably high levels of MRD. Some of the most exciting prospects for the future have emerged from the development of specific agents that target cancer cells more specifically than the rather brutish approach of surgery, radiation, and chemotherapy, where normal tissues suffer collateral damage. Using immunologic approaches, we have some new agents that target specific antigens on the surface of tumor cells, notably rituximab that targets the CD20 molecule on the surface of B-cell lymphomas, and antibodies that target the CD2 molecule on the surface of neuroblastoma cells. Here are the results of treatment of children with advanced neuroblastoma with an antibody to the GD2 antigen present on tumor cells. When this therapy is administered to children after intensive chemotherapy and autologous stem cell transplantation, a clear benefit can be demonstrated compared to children who did not receive the antibody. We are thus able to eliminate tumor cells that have survived the initial intensive therapy that had already been administered. Antibodies that target the CD30 molecule on cells of Hodgkin disease and anaplastic large-cell lymphoma are also now available. A significant advance has been the development of agents that conjugate toxins to these antibodies. Here is an antibody toxin conjugate developed by Seattle Genetics. The antibody to the CD30 antigen is linked to a tubulin toxin, MMAE, that can be activated intracellularly. The antibody binds to cells that express the CD30 antigen, that would be the malignant cells of Hodgkin disease and anaplastic large-cell lymphoma, delivering the toxin to the cell. The toxin is cleaved from its linker and activated in the cell. The mechanism is shown in this cartoon. The antibody serves as a drug delivery system as it binds to its target antigen and is endocytosed. The toxin is released and poisons the cell. Harnessing the capacity of T cells to destroy tumor cells has been one of the most exciting recent advances. In this strategy, T cells from the patient are re-engineered by adding the specificity of a monoclonal antibody to the patient's own T cells by combining the antibody-derived binding domain to the intracellular signaling domain of the T cell, targeting the T cell to a tumor antigen. The result is a chimeric antigen receptor T cell, or CAR T cell, that can recognize a cell expressing a specific target antigen and kill it. Here is a cartoon of the engineering of the T cell by adding the specificity of the antibody binding region of an antigen binding region of an antibody to the intracellular signaling machinery of the T cell. Cells are harvested from the patient and engineered with a retroviral vector that codes for the CAR gene. These re-engineered T cells are then expanded in vitro. Meanwhile, the patient is treated with lymphocyte-depleting chemotherapy, allowing the reintroduction of the re-engineered CAR T cells into the patients. Such T cells survive for months and kill any cells encountered that express the target antigen. The strategy has proven to be remarkably successful, producing durable remissions in patients with refractory leukemia. But new approaches that do not depend on the host immune system are also being explored. Optimism about the future is inspired by developments of the genomic era that hopefully stand as the new paradigm for progress. Pathways that drive malignancy have proven to be promiscuous. The number of relevant pathways is finite, and they are important in disparate tumors, so that targeted therapies should find applications against multiple tumor types. Remember Imatinib, or Gleevec, that was developed for Philadelphia chromosome-positive CML and pH-positive ALL that I talked about earlier? Well, gastrointestinal stromal tumor, or GIST, is a tumor that does not respond to chemotherapy or really to anything. Well, it turns out that fortuitously, Imatinib also inhibits the c-KIT and PDGFR kinases that drive GIST. So a drug developed for leukemia turns out to be very active in a very refractory solid tumor that is totally unrelated to leukemia. You can see here how the tumor has been treated with Imatinib. This has revolutionized treatment for GIST, just as it had revolutionized treatment for CML. It is apparent that what applies in the application of Imatinib to tumors as diverse as leukemia and GIST may be the rule rather than the exception. Similar considerations apply to medulloblastoma, a pediatric brain tumor. We now know that medulloblastoma, by analogy to what I showed you in leukemia, is at least 4 different diseases that can be sorted by molecular studies, each driven by a different pathway. One subset of medulloblastoma appears to be driven by the sonic hedgehog gene pathway. When a specific inhibitor of the sonic hedgehog pathway was used in a patient with widely metastatic, refractory hedgehog pathway-driven medulloblastoma, a near miraculous response was observed, and you can see the disappearance of all areas of hypermetabolic activity on the follow-up PET scan on the right. Unfortunately, cancer cells are smart, and resistance via utilization of alternative pathways ultimately defeated this approach in this particular patient. The development of Crizotinib, an ALK inhibitor, is one more encouraging look at the future. ALK activation was discovered as the key molecular abnormality in anaplastic large-cell lymphoma. That ALK is a key mutation driving a rare subset of adult lung cancers provided an incentive for commercial development of Crizotinib, which is an ALK inhibitor that has proven to be very promising. But this development also proved to be fortuitous for pediatricians. In addition to its potential role in lung cancer, it is active against anaplastic large-cell lymphoma, which is a disease of young people. ALK mutations are also important in a subset of neuroblastomas. It is almost certain that the tissue context of ALK will have a major influence on the effectiveness that agents that target it. Results are certain to be different in lymphoma, lung cancer, and neuroblastoma. But such results demonstrate a new approach to drug development, not focused on the type of cancer alone, rather on the pathway that drives it. Thus, drugs developed for one tumor type are likely to be useful in multiple other tumors that share similar driving molecular pathways. Here, for example, is the response in a patient with refractory anaplastic large-cell lymphoma to Crizotinib. You can see the response observed between the before scans on the left and very shortly after administration of Crizotinib on the right. And responses that have been observed in children with anaplastic lymphoma and neuroblastoma have actually been durable. So what are the lessons that we have learned from our children and from the experience of pediatric oncology? First, care of patients with cancer and restoring them to health requires multidisciplinary expertise. Success depends on a wide-ranging collaboration of diagnosticians, therapists, and support services. It takes a village. The genomic era has brought stunning advances in our understanding of the biology of cancer. I hope that I have provided a convincing argument for the importance of collecting well-annotated tumor tissue from every patient. What we have achieved in ALL and neuroblastoma is already being demonstrated in virtually all pediatric and adult cancers. Understanding tumors on a biologic basis is necessary to determine the most appropriate therapy. If childhood ALL has taught us anything, it is that we should be astonished that our crude empirical therapies have been successful at all, especially in light of today's understanding that we have been treating an assortment of diseases with distinct genetic profiles having little relation to one another. Our children have taught us that cure is not enough. We must understand the consequences of therapies we prescribe and continuously modify them to eliminate agents associated with the most important late effects. We must be attentive to the host genome and the clues it can provide about individual patient susceptibility to acute and long-term toxicities of treatment. That is the vision of truly personalized oncology, understanding the profile of the tumor and of the patient to prescribe the best and least toxic treatment. There is another lesson that is familiar to pediatricians, that an ounce of prevention is worth a pound of cure. This is a lesson not just from pediatric oncology, but from pediatrics in general. Prevention strategy through immunization has proven to be one of the greatest triumphs of pediatrics and of modern medicine. Rather than diagnosing and treating diphtheria, widespread immunization simply eliminated it as a health problem in North America. The near eradication of measles, polio, and serious infections from H. influenza is a similar triumph. In the management of cancer, our best strategy would move us from the paradigm of diagnose and treat to one of predict and prevent. Here, too, pediatricians may hold the key, since the best opportunity to prevent cancer in adults is proper immunization and lifestyle counseling of children. Successful immunization against hepatitis B and human papillomavirus presents the prospect of preventing much of hepatocellular carcinoma and cervical cancer, and perhaps a substantial portion of head and neck cancers as well. We can only hope for equally successful vaccines against Epstein-Barr virus, hepatitis C, and Helicobacter pylori. And pediatricians can also influence children and families to promote healthy lifestyles and to educate them about the dangers of smoking, obesity, and ultraviolet exposure, the major risk factors for preventable adult cancers. But all this newfound insight into these diseases and their treatment is only as good as our ability to deliver what we know. Drug shortages, primarily of generic, sterile, injectable drugs, have emerged over the past few years as a growing threat to the well-being of our patients. Such shortages are having a major impact on cancer care. Multiple factors are responsible, and there's no obvious solution in sight. The number of drugs in shortage has escalated over the past few years. It involves multiple drug classes, many of which affect the care of our patients, including at least 23 chemotherapeutic agents that have been in short supply during the past few years. Some of these drugs are key ingredients for curative therapy for several pediatric and adult cancers. Other drugs in short supply limit our efforts at supportive care. Here is a listing of chemotherapeutic agents in short supply in September of 2014. It is difficult enough to cure children with cancer. It is nigh impossible without many of the agents that have been proven to be critical to successful treatment. The current chemotherapy shortage is emblematic of the precarious nature of the path between discovery and the delivery of our most exciting new findings. We can rejoice in our growing understanding of cancer and its translation to better therapies in the clinic, the discovery phase, but we must also focus on our capacity to deliver on what we know. Disparities in access to high-quality care is a grave concern. Just 2 years ago, almost 50 million Americans, or 16% of the population, had no health insurance, putting them at considerable risk for personal bankruptcy in the event of a serious illness. The roles of the uninsured include 1 in 4 working adults and 10% of children. Although the Affordable Care Act promises to remedy this situation somewhat, 35% of children are insured through Medicaid. This reality has an enormous impact on the delivery of cancer care. It is clear that being uninsured is a risk factor for substantially worse outcome, and it appears that the outcome of patients covered by Medicaid is not that much better than for uninsured patients. Obviously, a number of factors beyond insurance coverage can contribute to this finding, but the data are compelling. And there are other distress signals that should give us pause. Oral, targeted agents promise to revolutionize the treatment of many cancers, yet the high cost of these agents and the high insurance copays frequently make these drugs unaffordable, even for patients with health insurance. Targeted therapies that are being added to our armamentarium against cancer are only worthwhile if patients take them, and that is only likely if our patients can afford them. And we have not begun to address the obstacles to delivery of what we know to the developing world. 85% of the world's population lives in low and middle income countries. For children with cancer, it is in a resource-poor country, it is a matter of life and death. While 80% of children with cancer in resource-rich countries will survive, in resource-poor countries, 80% of them will die. The result is an intolerable survival gap between haves and have-nots. Cancer is a global problem that will require innovative solutions. Any update on pediatric oncology would have to be viewed as a success story. The progress we have made is breathtaking. We now cure 80% of children with cancer, and we continue to strive to minimize the cost of cure by modifying therapy to reduce the acute and late effects. But there is still work to be done. We cannot yet cure every child, and the price of cure remains unacceptable. But the future is bright, with many novel strategies emerging from our investment in basic and translational research. And of course, we must assure access for all children to our best therapies. Thank you.